So hello to all aspirants, welcome you all to Sail to MDS Dental Academy. So aspirants, I hope you all are working well, and because just 6 months are left for your examination. So let us start the lecture with some positive note. So we have 3 things in our life whenever we want to do something. That is the idea, plan and action. Of this, the action is very important. Whatever type of idea and planning you do, if you are not doing the action, it is of no use. So I want to tell to all my aspirants who are part of my academy and to other students also that please go on action. I know a lot of you are confused in making plan, in making good plan, but it's of no use unless and until you are going with the action. So aspirants, a lot of things I have been sending and sharing through you with the video, that how you have to study, how you have to refer the textbooks, how you have to solve the MCQs. So those are our experiences and those are our short strategy success. So try to follow. It is going to bring change in your preparation. Once you try, just for a one topic also, for a half a day also, for a subject also, you will feel the change. Okay? And I don't like my students to go for the unnecessary excessive bulky learning, because along with learning you have to go with the revision also. I've seen few students, they study some 10 to 12 books for a subject, and then when they come just one month for examination, they are not able to revise properly. What will happen in the end? Nothing you are going to get. So please make proper idea, plan well in concise manner, not very short, not very big, concisely, and go for the action. So let's start with the lecture. So today the topic is image based questions. We will study endo, operative and radiology. So first we'll talk about the ICDS classification, that is International Caries Disease Assessment System. So it's very important because nowadays commonly used everywhere, so they can ask you any of the pick and they tell you which code it is, which ICDS code. So don't get confused aspirant. It ranges from 0 to 6. 0 is your sound tooth surface. You can see, you cannot see any caries or hyperplasia or any demineralization. So 1 and 2 indicate initial. So in what you can see in 1, you can see slight demineralization, means first visual change in your enamel. Okay, most commonly it is seen after you dry the tooth surface. What you can see in the code 2, you can see distant visual change in the enamel. Often it looks like wider fissures. What you can see in the stage 3 and stage 4, they are moderate. In stage 3, the enamel breakdown occurs, but you cannot see any denting. Whereas in stage 4, along with the enamel breakdown, you can see the underlying dark shadow of denting. What you can see in the 5 and 6, they are the extensive. In 5 you can see distant cavity with visible dentin, wherever in 6 you can see extensive cavity with dentin, and here the cavity is deep and they may involve half of the tooth. So these are 7 codes for your ICDS classification. Now let's talk about cusp capping. So everybody know the rules, but when they come to the image based question, often they tend to make the mistake. So we have to calculate the distance between the primary groove and cusp tip. If it is half, no need of cusp capping. If it is around 2/3, you can consider cusp capping, but if it is more than 2/3, the cusp capping is mandatory. So this is your half a distance aspirant, this is your 2/3, and this is your more than 2/3. If it is more than 2/3, go for the cusp capping. Now let's talk about curing light aspirant. So we know just one curing light because in college most often we have seen such light emitting diode, but there are other curing light also which examiner can ask you in the form of your MCQ or image based question. So what is this? This is your QTH. That's a quartz tungsten halogen curing light. So what happened? What the mechanism in this aspirant? They have, the name only suggests quartz tungsten halogen light. So they have one halogen bulb and one filament of quartz tungsten is there. So this halogen get heat up and they will send the heat to this filament and it get heated and we will have the light. The light has the wavelength of around 450 to 500 nanometer. So this is your QTH. But the disadvantage of the halogen bulb is that it works for around just 100 hours. So they have very less shelf life. What is this? It's a plasma arc curing light. So when it was developed in around 1990s, it was developed with a view of rapid curing. You know what will happen? They will generate the high amount of heat, which will ionize your xenon gas. They have xenon gas. So this xenon gas will ionize and they will release the plasma arc. So that is your plasma arc curing light. Fine. So let's see them in more detail. So halogen, the advantages are low cost and they are the longest history in dental industry, means they are the commonly and conventionally used curing unit. There are few disadvantages like efficiency is very low, short service, they will generate very high temperature which can be detrimental to your pulp also. So ventilation fan is required, and they produce a light in continuous spectrum. It means what, aspirant? When you start the polymerization, they will start with a very low polymerization, and at the end of your polymerization cycle it will become very high. That's why they should be narrowed by the filters. Then we have a plasma arc curing light. They have a very short polymerization type, around 6 to 9 seconds, but the disadvantage is that they have very high cost along with the about disadvantages. Then we sometimes use laser also for the curing. The laser used for the composite is your argon type of laser. They have very low heat generation. The disadvantage is that the high cost is there, and they will generate very high energy, around 200 to 300 milliwatt, which will be detrimental to your pulp. Then we have LED, most commonly used. There is a light emitting diode. So if you want to know the exact value, they produce the blue light of wavelength 455 to 486 nanometer. So you require no filter. They have very high efficiency and they have long shelf life, around 10,000 hours. Fine. They have few cons, that there's emission is very narrow. So they polarize between 440 and 480 nanometer only, and the CPQ means camphoroquinone. So this LED can use only for those composites which have camphoroquinone as photoinitiator. Fine, so these are few important points regarding your curing bulbs or curing units. Now let's talk about burrs for amalgam preparation. So aspirant, this is your 245 burr. The width is 0.8 mm and around 3 mm you can see the length. This 330 is the miniature of your 245 burr. 330 most commonly used for the amalgam preparation, class 1 cavity, and 245 is used to create the occlusal convergence buccal. You can see slight convergence is there. So you can use to create convergence of your buccal and lingual walls. At the same time, they have rounded angles. So you can use them to make your internal line angles rounded. So these are your few burrs for amalgam preparation. Let's talk about the grasp. So students often tend to confuse. So this is your pen grasp. So you can see the side of your middle finger is on the writing instrument, where when modified pen grasp, the side of the middle finger is on the top side of the instrument. So because of that, you will get the good control and cutting pressure. And if you talk about the rest, it can be the tip of your ring finger, or you can use the tooth on the same side. So these are your two different pen grasps, conventional and modified. This is your inverted pen grasp. So this grasp is commonly used for preparing a tooth in the lingual aspect of your maxillary anterior and occlusal surface of your maxillary posterior teeth. Remember aspirants, in this inverted pen grasp, the palm will face more towards the operator. Then we have modified palm and thumb grasp. This provides more control to avoid slipping of the instrument. It is commonly used for your maxillary anterior teeth. Then let us talk about few cross section of different files. So we have triangular cross section in case of flex R file, K reamer and K file of larger type. Then we have a square type of cross section in K flex smaller and K reamer and K file of smaller type. We have a rhomboidal kind of cross section in K flex larger file. We have such teardrop cross section in case of your H file, and S shape, that is a non-cutting tip, we have in case of the uni file or S file. So please aspirant know this different cross section. Many times they have asked in the exams. Now what are endosonics? So whatever ultrasonics you use for the endodontics, they are endosonics. So their two main mechanism of action, that is the cavitation and acoustic streaming. Such endosonics you can use during your each and every step of your root canal therapy. You can use for your access enhancement, orifice location, use for them irrigation. You can also use them for the MTA placement and sometime for obturation also. So these are your endosonic files of different numbers 6, 7 and 8. Please note the color coding for them. For 6 it is pink in color, 7 it is blue and 8 is green in color. So this is endosonics. Then let's understand the difference between your spreader and plugger. So spreader you can say is a thin pointed and plugger you can say the blunt end. So this is the example of your finger spreader, and this is your hand plugger, and this is your finger plugger. Now let us see Lancero spiral. It is one of the ideal instrument for placement of your root canal sealers. It is also used for primary teeth obturation. So please know this is your Lancero spiral. Now let us talk about few endodontic mishaps. Already we have discussed in detail in our lecture, but let's see more detail. So what's ledge? Ledge means internal transportation. So because of ledge, what will happen? Your file will not able to go to the original apex. Then we have apical transportation. It means what? You are changing the apical foramina of the root. So you can see this is your natural apical foramina and where it changes because of your transportation. And perforation is simple thing, is the connection between your internal and the external environment. So please note these three important endodontic mishaps. Then thermophile cones and thermophile obturator. So aspirants, what you can see here, something has been coated on this cone. This is your Kattaparka cone. So it is one of the solid core carrier obturation system known as thermophile. So they have thermophile cones and thermophile obturator. Then this is your MTA carrier used for the apexification, and you can also use in case of your pulpotomy when used for the MTA. This MTA carrier will help in carry MTA into your pulp chamber and as well as to the root end. So aspirants, this is your MTA carrier, most commonly used in case of the MTA apexification and the MTA pulpotomy. So this will help you in carrying your MTA. And this plunger will come which will force the MTA. Then aspirants, let us understand the difference between Obtura 2 and ultrafil. Many students make mistakes, so I am revising again. So Obtura 2 have very high temperature. They have a gun with a heating element, and there are 4 types of needles. There is 18 gauge, 22, 20 and 25 gauge. They display the temperature of the Obtura 2, and the working time of the Obtura 2 is around 3 to 10 minutes. But the ultrafil, the name only say ultra, means everything is low. Like the temperature is low, there is no heating element, only one needle. But the disadvantage is that they have no digital readout, and the working time is less than a minute in ultrafil. Now aspirants will study about few motions of instrumentation. So what this image depicts, this is the example for your balance force technique, where 1/4 you go for the clockwise and 3/4 you go for the anti-clockwise. Let's see another motions. Like this is your push and pull, this is your reaming, this is your turn and pull, this is your watch winding motion, and this is your balance force technique. So aspirants, try to understand each motion. Anyone can be your question. Now these are few access burrs. Okay, they are known as safety tip taper diamond burr, and this is your safety tip carbide burr. Then these are your another access burrs. This is your Mueller burrs and this is your Allen burr. They are used commonly. These access burrs are used commonly when your pulp chamber is receded or calcified. They can be good orifice locator. So this is your Mueller burr and this is your Allen burr. Now what is this? This is the pink tooth of Momeri. So example, they can ask you which AIIMS classification. It is your AIIMS class 4. Then these are your quartz fiber post, and these are your active threaded metal post, and these are your passive serrated metal post. So these are your active threads which will engage in the dentin of your root surface, and these are passively placed in your root canal. So please note the difference between this active and passive post. Now what does this symbol represent? This represents the biohazard, and what this represents? It represents the radiohazard. So please note the difference between the bio and radiohazard. Then we'll talk about few Xray films. So aspirants, we have 3 types of periapical films ranging from size 0 to size 2. Please note the value for each of them. Size 0 is 22 into 35 mm, size 1 is 24 into 40 mm, size 2 is 31 into 41 mm. And these are bite wing films. We have 4 types: size 0, 22 into 35, size 1, 24 into 40, size 3, 27 into 54, and size 2 is your 31 into 41. An occlusal film size 2 type commonly used in our dentistry, that is 57 into 76 mm. So these are few review of your Xray film. So in exam they can ask you question like this. So where you can use your size 1 periapical film? So you have to answer it is for anterior adult projection. Let's see a few radiographs. Now what this indicate? This indicate your mesiodense or supernumerary tooth between your central incisors. What this indicate? Aspirants. What this is? A small discrete denticles. This indicate your compound odontoma in anterior maxilla. This is what? It is the complex odontoma. Remember, your complex odontoma resembles your dental tissue, and most often you can see complex odontoma in the posterior part of dentition. What this different, we can say this is an oblique lateral radiograph. What they see, you can see here the dentigerous cyst. Okay, this is the circumferential type of your dentigerous cyst, and you take the occlusion radiograph to see the expansion. So you can see the beautiful buccal expansion, which is commonly seen in your dentigerous cyst. And remember, aspirants, wherever there is odontogenic keratocyst, you can see the lingual expansion, not buccal expansion as seen in your dentigerous cyst. Now what this indicates? So this white arrow indicates your anterior nasal spine, and this black arrow indicates your typical nasopalatine duct cyst, most commonly seen in the midline between your upper central incisors. Then what is this aspirants? This is the radiolucent area. So the solid things you can see, that is your solitary bone cyst. So please aspirants, don't confuse between the solitary bone cyst and traumatic bone cyst. So whenever the traumatic bone cyst is there, you can see only radiolucency below your roots. But in case of solitary bone cyst, this radiolucency will extend between the roots of the teeth. You can see this arrow. So whenever such radiolucency extend between the tooth or root of teeth, it is your solitary bone cyst. This is what? A characteristic sunburst, or we can say sunray appearance of your osteosarcoma. And you can see in this panoramic radiograph aspirants, ragged or mouth-eaten appearance. This is the ragged or mouth-eaten appearance, most commonly seen in your squamous cell carcinoma. Now, along with the disease, you must know the normal radiographic landmarks. So let us understand this anterior maxilla. So aspirants, first we'll see the midline. This is your nasal septum, which will become your anterior nasal spine around your tooth. Please remember. Then you can see this is your intermaxillary suture, and here you can see your alveolar crest. This radiopaque area is your enamel. This little radiolucence you can see, that is your dentin, and this is your bite block. And in the center you can see the pulp. Along with this, this is your nasal fossa, and this is your inferior concha. Then you can see here the little radiopaque shadow, that is your tip of the nose. Here you can see the incisive foramina. This radiopaque area is your lamina dura, and this radiolucent space is your PDA space. So aspirant, please note these landmarks of your anterior maxilla. Now we'll talk about posterior maxilla also. So this indicates your anterior border of zygomatic process of maxilla, and this is your posterior border of zygomatic process of maxilla. And this thickened, or we can say the more radiopaque area, is your zygoma. And this is the floor of your maxillary sinus. Remember, it is most closely related to your first maxillary molar. And this you can see this radiolucent line. This is your nutrient canals in maxillary sinus. Now let us see the posterior mandible. So this is your mental foramen, most commonly associated with your second premolar. This is your nutrient canals. This radiolucent area, little haze area, is your submandibular gland fossa, and this thickened area is your mylohyoid ridge. Now let's see the other features. This opaque border is your external oblique ridge. This opaque line we can see, this is your mandibular canal. This is the inferior border of the mandible, and this is your mental foramina, closely associated with your second premolar. Now let's see some technique and projection error. So aspirant, this is your double image. So you can see here posterior teeth also and anterior teeth also. Why it happens? When your exposed film is re-exposed. So aspirants, this is your reverse film. Okay, it is also known as herringbone or tire track or dotted pattern. So why it happens? Normally what happens? The lid side of your X-ray we will keep away from your X-ray beam. But if you place in wrong manner, that is a lead fold side towards the X-ray, such reverse film you can see. Then we have projection errors like incorrect vertical angulation. If it can result in two things, that is the elongated image and shortened image. So you can see this is the example of your elongated image, and this is your foreshortening. Then why you see the higher density image means when you see the more darker image. Remember aspirants, whenever anything is very high, like your MA is high, your KV is high, your time is high, your developer temperature, concentration, developing time is high, you can see high density image. Only one thing comes short here, it is film source distance. So remember this shortcut, for high density image everything should be high except your film source distance. Then we have few low density image, here everything is low, like old developer solution, low temperature, low time, low concentration and incomplete fixation. Then aspirants, there are few handling errors also, that is static electricity. When it happens, when the two surfaces of your X-ray are rubbed together against each other, they will create an electrical charge, okay, with visible light, and they expose your X-ray, leading to such static electricity. So these are the one of your handling errors. So aspirants, that was all for the today image based questions. So I have point out few important images, and you can check out our lectures also where the other images and explanation is there. If any doubt, you can contact me. Till then aspirants, take care, study hard, and please make proper timetable, follow the pyramid which we have discussed, that is your synopsis notes, MCQ and reverse study of your textbook.